It is 8 o'clock, and
Mhm.
I will get started with an introduction to Dr. Jessica Gaulton. But prior to that, I just want to welcome everyone. Thank you for being here with us this morning for our monthly ABIN webinar. Today, we are going to be talking with Dr. Jessica Gaulton about prenatal and maternal health and what does COCM look like in that population. I want to remind everyone that by staying on today's call, you are giving us your permission to record, and we will be recording this session and posting it to the ABIN webinar. We will also have slides available. So those slides will be on the webinar. Give us about a week or so to get those materials edited and uploaded. Please put your name, organization, and in the chat. We'd love to know who's here with us. And now we are going to introduce Dr. Galton. Okay, so we have Dr. Jessica Gaulton. She is a physician entrepreneur whose expertise lies at the intersection of maternal and newborn health and healthcare innovation. She is a practicing neonatologist at Harvard and also founder and CEO at FamilyWell Health. FamilyWell's mission is to provide high quality, equitable, and affordable access to integrated mental health services for women throughout their reproductive journey. Dr. Gaulton received specialized training in innovation and design at the Penn Medical Center for Healthcare Innovation, a clinical fellowship in neonatology at the Children's Hospital of Philadelphia, Penn Medicine, and a medical degree from the Johns Hopkins School of Medicine, a master's of public health and health policy and management from the Harvard School of Public Health, and pediatric residency at the Boston Combined Residency Program at Boston Children's Hospital, Harvard Medical School. Wow, that's a lot that she has accomplished, and we are so excited you are here to share the information with us today. We also want to ask, Dr. Galton is saving plenty of time for questions. If you have questions, please don't hesitate to put them in the chat as we go, and we will be addressing all questions at the end of the presentation.
Well, thank you so much, Kim and Aben and Dr. Patty Gibson. Huge shout out to you for connecting me to this wonderful group, and really honored to be here today. And this is my favorite topic, and I could go on and on and on all day, and very pleased to have this hour with you. So, gonna start off by just sort of giving you an outline of what we're going to be talking about today. We'll be reviewing three main objectives. So first objective, we'll be talking about for about 10 minutes, talking about the prevalence and impact of perinatal mental health conditions and the need for integrated behavioral health models. Objective number two, I'll explain the key components of the general collaborative care model, and then how FamilyWell's model builds on that. And we'll be talking about FamilyWell's workflows for screening, referral, and care coordination. And then the last section, we'll have about 25 minutes to do a Q&A. And please feel free to pop in questions as we go in the chat that I will address in the last section. Any strategies or lessons that you want to hear about from my own experiencing building this company, and I'm happy to share. All right, so let's dive into the prevalence and impact of perinatal mental health conditions and why we need integrated care models. So many of you may know that the number one cause of pregnancy-related death, so that's pregnancy-related death means in pregnancy or in the postpartum, is from suicide. And 80% of these deaths are preventable. It's really important to know that, with treatment, these deaths can be avoided. And the biggest barrier to preventing these deaths is access to care. So when you hear the term PMAD, the PMAD stands for the perinatal mood and anxiety disorders. It's the umbrella term that encompasses any mood disorder that develops during pregnancy or in the year postpartum. So it's a 2-year time frame. It doesn't just include, I mean, we talk a lot about postpartum depression. We hear a lot about that in the news, about psychosis. But actually, PMADS encompasses perinatal depression that starts in pregnancy, right? So we typically refer to it as perinatal depression, not just postpartum depression, perinatal anxiety, panic disorders, bipolar disorder, psychosis, OCD, and PTSD. All of these mood disorders, if they develop in the perinatal period, are under the PMAD umbrella. And also, really important to know that most pregnancy related deaths actually occur between 6 weeks and a year postpartum. So, for those of you who've had babies, who've had kids, you may remember that typically, when you see your OB-GYN provider 12 to 15 times during pregnancy, and then typically you see your OB-GYN provider in the postpartum period around 6 weeks. It's becoming standard of care across the country that we're extending out postpartum care through a year. And one of the most important reasons is because of this risk of, developing or worsening mental health conditions and that lead to suicide and overdose in this time frame. So really important to know that, 2/3 of these deaths are occurring after you see a doctor, and typically between 6 weeks and a year postpartum, most women are not seeing anyone, right? They're sort of left without care. A lot of the attention, the medical care attention is on the baby. And untreated PMADs, perinatal mood and anxiety disorders, lead to poor health outcomes, both for the birthing person, typically the mom, and the child. And not just that, but to the whole family. So when we look at the birthing person and her risk factors, downstream morbidities, increased risks of suicide, obviously, increased risk of preeclampsia, increased risk of length of stay, increased risk of C-section and other complications during delivery. So the cost of a hospitalization for delivery actually goes up. And then on the baby, on the child side, the risk of SIDS, so sudden infant death syndrome, goes up significantly. The risk of delivering prematurely and having your baby in the NICU goes up by 2.5-fold. And then the child downstream, as they get older, have increased risk of behavioral health and developmental disorders as they get older. And obviously, this affects the whole family, right? And actually, for partners, if the birthing person has a mood disorder during the postpartum period, the partner, or typically the dad, they have a 50% increased risk of developing depression as well. So it affects the entire family. So starting with the woman, making sure that PMADS is treated appropriately is so fundamentally important for the entire family unit. And I include this slide because I'm a neonatologist and because I care so deeply about this particular issue. Untreated PMADS leads to an increased risk of delivering prematurely by, as I mentioned, 2.5-fold. Your baby's then at increased risk of being in the NICU, right? That not only increases, morbidities, but also increases cost. And then the reverse is also true. So if you have a baby in the NICU, but you're the birthing person, you didn't have a history of a mental health condition, your risk actually goes up by 75% of having a positive EPDS. The EPDS is the Edinburgh Postnatal Depression Scale. And that picks up screens for depression and to some extent anxiety among perinatal individuals. So it's a vicious circle. It's a vicious cycle. And breaking that cycle and treating PMADs during pregnancy or even preventing them is so, so important for preventing premature delivery. And then this costs a lot of money on society, right? The total societal cost has been estimated to be $14 billion. I actually think these data are pretty old at this point. We don't have any updated figures since 2020, but I actually think this is a significant underestimate. But based on this paper that came out in 2020, it was a Sentinel paper. About 2/3 of the cost, the societal cost, goes towards the mom, and then about a third to the child on the pediatric side. And I just have to give you a little anecdote, a little story about my own experience as a neonatologist. When I was in private practice before I started FamilyWell, the impetus for me to start this company really was I was practicing 100% clinically at a private practice outside of Philly. And at this practice, we followed patients, we followed families after discharge from the NICU in our NICU follow up clinic. And during COVID, I saw mom after mom after mom struggling with her mental health, and I had nowhere to send them. So what we did at this particular hospital, which is very common at most, medical institutions, is we had a piece of paper, we had a list of therapists in the community that hadn't been updated since the 80s. Because what I did was I took the list, I called every single therapist on that list, and most people did not pick up. Some of those numbers were outdated or disconnected. And what we were instructed to do as physicians was give the families this list and let them figure it out, right? First of all, it's really hard to get off of a wait list for a therapist, even if you have the right number. Mostly you have to pay out of pocket. In the Boston area, the cost of a therapy session, a single therapy session, is somewhere between $250 and $400 per hour. Most therapists don't take insurance, and most therapists are not specialized in perinatal mental health, on women's mental health needs. And so it is incredibly, you can imagine how hard it is to access therapy. And not everyone wants or needs therapy as a first step, right? So, um, how I felt as a provider is a very common feeling amongst OB-GYN providers, pediatricians, anyone on the ground taking care of these patients, is that we have nowhere to refer our patients for mental health support. This is the fundamental issue with the access barrier. One of the fundamental issues to access barrier, also mental health provider shortage. The mental health provider shortage, excuse me, is also a huge barrier to getting help. Um, but this is sort of a first step, and this is fundamentally why we need to integrate behavioral health into traditional medical care, into OB-GYN care, so that it's just baked into your care when you get pregnant, or you go to see your obstetrician or gynecologist or pediatrician or primary care doc. When you get medical care, I believe that you should have the emotional wellness component baked into your care. So, we're going to move on to explaining the components, the basic components of FamilyWell's collaborative care treatment model. I'll give you a little bit of a background on collaborative care as the original model as it was conceived, and how our model is slightly different and designed for women. We'll talk a little bit about our workflows, screening, referral, and care coordination as well. So, how did a neonatologist like me, how did I get into behavioral health? I never planned to do this. Um, the reason why I'm doing this and I'm so passionate about this topic is because I struggled with postpartum depression myself, and I am very privileged and grateful to have had the opportunity to train and work at three of the top medical institutions in the country, and I could not find help. It's very stigmatized. I'm a physician who takes care of babies and families, and I felt like I had to be the strong one. I couldn't be weak. I couldn't expose that I was struggling myself. And beyond that, when I did finally recognize I was struggling, there was nowhere to go. And I trained at two of the top children's hospitals in the country. And so this is why I'm so passionate about our mission, and this is why I'm doing the work that I'm doing. And actually, this is a picture of my son, Will, who, right after he was born, and I don't think anybody around me could have guessed that I was struggling to the extent that I was, not even my husband. So I hid it well. And a lot of people around you might hide it well. And so I believe that talking about our stories, and actually that's how FamilyWell became FamilyWell, is that I started talking about my story, and all these people that I knew and very close to in my life came out of the woodwork and said, "Oh my gosh, I had the same experience." So, our mission at FamilyWell is to solve the women's mental health crisis by embedding evidence based, equitable, and affordable mental health support into OB/GYN care. So, FamilyWell partners directly with OB/GYN practices, whether you're private, whether you're owned by a hospital, whether you're, um, a private equity backed clinic. We would love to work with you. We also work with large health systems. And currently, FamilyWell is in 5 states across the country, covering 200,000 lives. And we're so privileged to be able to work with these incredible women. We started really sort of squarely in perinatal mental health. And, for obvious reasons, my own lived experience, my passion around this area, we also wanted to really refine and a new we really pioneered a new care delivery model and wanted to get that right first. And then over the last several years, our clinic and health system partners across 5 states that we're in asked us to expand our breadth of service offerings because, women who are struggling with infertility also need mental health support. So now we really cover the whole reproductive journey, starting with infertility or fertility, through the perinatal period, through any birth challenges that you may have. And then most recently, we expanded our service offerings to include perimenopause, menopause, and then struggles on the GYN side. Because our OB/GYN providers, clinics, they do both, right? They do obstetrics and they do gynecology, and they want to be able to offer FamilyWell to anyone with struggling with a mental health condition. So we'll treat any condition as long as it's appropriate for the outpatient world. So if a patient needs to escalate to an IOP, a PHP, or an inpatient unit, then we'll escalate them out of the program. But it doesn't happen too often, fortunately. All right, a little bit about the collaborative care model. You may or may not have heard of the model. I'm just going to sort of give you a little bit of the basics, and happy to answer any more sort of mechanical questions or specific questions in our last Q&A section. So the psychiatric collaborative care model, you'll hear it called COCM or COCM. We at Family will call it COCM. It is a model, and you probably hear collaborative a lot in healthcare and behavioral health. This is a very specific model that's been around for decades, that was sort of birthed at the University of Washington. And you may have heard of the AIM Center. I mean, they pioneered this model and studied it rigorously for decades. So there are over 100 clinical trials showing that this integrated behavioral health model, essentially integrating um, specific components that I'll go over into medical care, and specifically in this case, they started in primary care, improves clinical outcomes, reduces health disparities, and lowers cost. So there's a robust ROI for payers, for health systems. And this model has been validated in clinical trials across all medical, not all, I shouldn't say all, many medical specialties, including OB/GYN care. These billing codes were adopted by CMS in 2017 and are becoming standard of care across all medical specialties, much more so in primary care. And when I learned about this model, I said, oh my gosh, this is a no brainer. You can get paid to integrate mental health into your practice. Why are we not doing this in OB/GYN care? It's simply because OB/GYNs just don't know about these codes, and there aren't options for them to partner until FamilyWell came along. Um, there's been really rapid adoption of these billing codes across all major commercial plans across the country. And then 36 state Medicaid plans have adopted these codes. Like, already there in your fee schedule, you can start billing those codes right away. In terms of the collaborative care model components and the team, you have to meet certain criteria to be able to bill for these codes. So typically, you have a medical provider who partners with a behavioral health care manager and a psychiatric consultant. The medical provider in this model is the billing provider. So these collaborative care codes are fee for service codes on the medical side. Really important to know, they're not on the behavioral health side. They're not behavioral health carve out codes. They are medical codes that only the primary care doc or the OB-GYN or a medical specialist can bill for. The behavioral health care manager is typically a social worker, although you don't have to be a social worker. You don't have to be licensed. The minimum requirement is a BA in psychology, social work, or nursing. Um, and so you don't have to be licensed. However, a lot of collaborative care programs do choose to have a licensed provider or social worker typically filling this role. The behavioral health care manager manages the patient registry. So essentially, they have a bird's eye view of all the patients in the collaborative care program and are monitoring their progress and coordinating the care, getting patients to their visits, reminding them about their mental health screenings, et cetera. So a lot of the logistics this behavioral health care manager oversees. And all of that time that the behavioral health care manager is spending coordinating care is billable time through these codes. The psychiatric consultant is a really key component of this model as well. This is typically a psychiatrist, an MD, or it could be a psychiatric nurse practitioner, doesn't have to be an MD, who advises and consults on medication management. So really important to know that the original collaborative care model, as it was conceived, um, the psychiatric consultant does not see the patients directly. They are doing case reviews. So they're looking at sort of a synthesized summary of the patient's story. And they're saying, okay, I recommend starting Zoloft at 50 milligrams, right? And then it's the medical provider who then prescribes the medication. So the psychiatric consultant is a consultant. And the reason why this is important to scale psych is because when you see a patient, it takes about, depending on, whether you're doing an initial consult or a follow-up visit. Typically, you're seeing one patient an hour. Now, in this model, you can review cases. We review cases in less than 2 minutes. So imagine how many more patients you can serve if the psychiatric consultant isn't seeing the patient directly, but just, directing and helping the medical provider with choosing the right medication, titrating up on the medication, on the dosage, and then getting the patient stabilized. Additional requirements you need to be able to build these codes. You have to have a registry. Some people use Google spreadsheets. I don't recommend that. Not HIPAA compliant and also hard to scale. We started with a very basic, essentially kind of like a spreadsheet that was HIPAA compliant. And then we realized in order to scale this model, we had to have a platform that really is able to capture all the minutes and synthesize the data for us and be able to show us the population health view of how our patients are doing. So we actually built a proprietary tech platform to enable our workflows and this model at scale. I don't think you have to do that though, just starting out. You have to do regular mental health screenings. Typically, you're doing PHQ-9 for depression or GAD-7 for anxiety at a minimum once a month, maybe more frequently depending on your program. And then this model, by definition, is a measurement-based model. You have to measure those outcomes. It's incredibly critical. So FamilyWell's collaborative care model builds on this foundation that was established before us. And we iterated on the model, innovated around the model to be able to serve, women and their mental health needs. So the key innovations and differences between the original model and our model is that we obviously all of our providers specialize in women's mental health. And even within women's mental health is super broad in and of itself, right? So like your experience and your struggles during pregnancy are so different than when you're perimenopausal, menopausal, and what your needs are at that point. So our providers tend to specialize in specific areas, even within women's mental health. We found a way to get coaching time covered under the collaborative care CPT codes. And then we also have a multidisciplinary approach. We recognized really early on that collaborative care by itself wasn't enough for this patient population. Initially, we were not doing direct psychiatric care. We were doing the original model where the psychiatrist is a consultant not seeing the patient directly, and recognized really quickly that we when we were referring patients out for direct psychiatric care, they were not getting access to that care quickly, if at all. And so we had to bring that in-house and actually do direct psychiatric care. Um, we also recognize that in the original collaborative care model, it doesn't cover therapy, right? Like traditional therapy. And some patients do need traditional therapy, ongoing therapy. So we also built out that service offering as well. So we do at FamilyWell direct therapy and psychiatric care because we really want to serve holistically the needs of patients, and provide them with a care team approach. Be able to sort of be fluid with their symptoms, right? You could enter pregnancy and have really mild symptoms of depression and or anxiety, and then postpartum, you're six months postpartum with a baby, and your symptoms worsen. We want to be able to flex up and the acuity and the intensity of care as your symptoms and your journey fluctuates. And then, as I mentioned before, we ended up needing to build a tech and AI enabled platform that supports our operations at scale. So at FamilyWell, every single patient that is referred to us, it gets a full virtual care team. So you get a certified coach, a therapist, a psychiatric provider, if meds are needed or if a case review is needed, and a care coordinator that you can text through our platform on demand with any questions. And then, our program, it was really, really important to me to be able to provide equitable, affordable access to our program. And so we are covered under insurance, pretty much all commercial insurances across the country, and also Medicaid. We do a lot of Medicaid. Um, the programming. So I think what's so important and so cool about so wonderful. There's so many wonderful things about my team. We're all women, and we've all had our own struggles. And the content of the program, the trainings for our providers, every part of the DNA of the program is designed and built by women for women who understand women. And so I think that is fundamentally critical, to be able to serve this population appropriately. You don't have to be a woman to serve the population appropriately. I just want to be clear, but we get it, right? And we designed around that experience. So in terms of care plans, what we typically do at FamilyWell is every single patient gets, as a first step, gets completes an intake, a psychological intake with a therapist. And so you can see our care plans broken down by acuity. Everybody gets a care manager. That person is coordinating your care, reaching out to you, sending you nudges, to reminder to fill out your mental health screenings, right? Everybody gets that and needs that. Everybody gets a coach. Our coaches, I'll tell you a little bit about our coaches and their background. They are the heart of FamilyWell. um, our coaches are women who have lived experience and who are trained and certified to deliver really high quality care, coaching care. So everybody gets a coach that is sort of their person that longitudinally stays with them throughout the time that you're with us. And then, as I mentioned, everybody gets an intake with a therapist. Now, not everyone needs or wants ongoing therapy, right? So everybody needs therapy as a first stop for the intake because coaches do not diagnose. So our therapists will do the intake, understand the history, make a diagnosis, and then from there, um, your care plan depends on your acuity level. So if you're low acuity, so low acuity means sort of mild symptoms of depression, anxiety, or maybe not even a diagnosis of any mood disorder. Maybe it's an adjustment disorder. Um, Typically you're going to have weekly virtual coaching sessions, and that may be all that you need. You may never need to encounter, never need to have a case review with a psychiatric consultant. You may never need direct psychiatric care. You may never even need ongoing therapy. So oftentimes in the low acuity category, it's virtual coaching until you feel better. And then in the perinatal phase, we encourage patients to, even when you're better, to stay in our maintenance program until a year postpartum. And the maintenance program looks like a monthly coaching session with monthly mental health screenings. Because of that risk of suicide and relapse between 6 weeks and a year postpartum. So we really encourage patients to stay with us until their baby turns a year. And we love celebrating the year birthday. We have really cute FamilyWell onesies that we send out. It's just a really fun time and a huge celebration at that point. So if you're medium acuity, this might be somebody who has low to moderate and maybe even severe symptoms of a mood disorder like depression or anxiety. You may already be on a medication, an antidepressant or anti-anxiety medication coming into our program. So you get care management, coaching every week, definitely an intake with a therapist and possibly ongoing therapy depending on your needs. And then a case review. So the case review is where the psychiatric consultant is looking at your history, like the entire sort of case, and making recommendations if a medication is needed or if we need to adjust your medication and your dosing. Typically in this category, you're not seeing a psychiatrist directly because that isn't needed. In the high acuity category, this may be a woman who has a history of postpartum depression or a history of a remote history of a suicide attempt or a history of psychosis or new diagnosis of a bipolar disorder. In this category, you're getting more touch points, more intensity care, and the full care team. So care manager coaching every week, paired with therapy, ongoing therapy, case reviews at least every month, but maybe more frequently depending on the need, and then direct psychiatric care. So you're going to see a psychiatrist directly through FamilyWell. I'm really, really proud to share our clinical outcomes. So this is our first clinical outcomes paper that's being published right now in collaboration with the University of Massachusetts and the Meadows Mental Health Policy Institute. We were able to show that we're getting access to, that patients are getting access to care within, in less than 24 hours. So it is a requirement of my team, of the care managers on my team, to reach out to the patient within one business day of the referral. So that is a requirement. And we're really proud that we're able to do that at scale. And we're able to get patients in to see a therapist for their intake in less than a week. 95% of our patients, perinatal patients, OB patients, achieve clinical improvement in 4 months. And so our active intensive phase of the perinatal program is 4 months. And then we encourage patients to stay in maintenance if they're not yet at a year postpartum. Not required, but encouraged. And within that population of patients who are getting better, 70% actually reach full-blown clinical remission based on their mental health screening scores in 4 months. So the average time to remission is 3.5 months. I absolutely love waking up and working with the team that I have. We have the most incredible, talented clinicians that I get to learn from every day. We have 3 incredible medical directors. Dr. Melissa Sherman, who is an OB-GYN provider. Actually, she was our first OB-GYN champion at our first clinic, and she has stayed with us and helped us build FamilyWell since then. Dr. Marissa Can, Dr. Lindsay Standevan, who are both incredible reproductive psychiatrists and collaborative care experts. And then Dr. Neil Shaw, who is an OB-GYN expert, who is the chief medical officer at Maven Clinic. So really, really proud of our team. So why do OB-GYN providers want to work with us, right? I mean, I think that a lot, you would think, okay, the logical question is, well, can we just build this on our own? It seems pretty simple. And yes, of course you can. Like, I encourage you to. And if you want help, I'm happy to help you. I think that it's really hard, though, if you are particularly a private practice physician, you are so slammed, you are so busy, you have a million things you have to do. You're trying to see so many patients a day. And OB-GYN providers, women's mental health providers, women's health providers, we all want to do the right thing for the patient, right? But sometimes we don't have the time, the training, or the financial incentive just isn't aligned. So by partnering with FamilyWell, we're able to get your patients access to care quickly. We're able to get patients better. We're able to decrease your workload. And then also the financial incentives are aligned with these collaborative care codes. And I'll tell you a little bit more about how that works. So by partnering with us, we work within your EHR, the OB-GYN providers EHR, the health systems EHR. So the notes and everything that providers need on the ground when they're seeing their patients, like it's a second trimester visit, right, with your OB. And most providers want to know how their patients are doing with mental health. They don't want to refer out and never hear back from the therapist or not have a collaborative relationship. They want to know. And they also want to know, if they're seeing a psychiatrist, what medications are you on? It's so critical to know that information if you're taking care of the patient during pregnancy or postpartum, or if you're a gynecologist, right? So we function within the EHR, we document within the OB/GYN's EHR, and so all of that information is at their fingertips. We also provide program management, right? We don't want to flood the clinic or the health system with additional questions about FamilyWell. We want to take that burden off of your plate and take on those phone calls, texts. So that's why we have it on-demand texting with our care managers through our platform. We'll provide your clinic or your health system with billing support. If you've never billed these codes before, we do. We have trainings, we have videos, we have a team that will support you to learn how to do this because it's super simple. It's not hard. It is hard on our end because it's operationally quite complex. But on your end, as a provider, there are 3 easy billing codes that you bill on a monthly basis. And then crisis support. We found over time, many states have psychiatric um, access lines. Like in the state of Massachusetts, there's MCPAP, and love MCPAP. I love that there is that access from in many states. However, those hotlines get saturated, and typically those hotlines are like sort of like a pop-off valve, right? Like you're a provider, you're taking care of a patient, and you have an immediate need. Oh my gosh, my patient is struggling with their mental health. I need to talk to a psychiatrist who understands this. Pick up the phone, call. It's typically a one-time call. They guide you, and then that's it. So we found that a lot of our providers at our partnering clinics and health systems wanted more than that. First of all, they found that it was difficult to get through to some of these access lines. And then secondly, they wanted us to be able to help triage those patients that are in crisis. Because imagine you're a busy private practice OB/GYN, right? And you have a patient you're seeing in your clinic um, who is saying, I'm worried I'm going to hurt myself. I need help, right? And so you as the provider, you stop in your tracks. You're kind of freaking out. I've done this myself. You lean on your staff. What do we do? How do we get this patient to where they need to go? And most of the time, because we have no options as providers on the ground, we send the patient to the ED. That is like the worst place to be unless you absolutely have to be there, right? So what we do at FamilyWell is patients with suicidal ideation, our partnering OB/GYN practices can call us, get a licensed provider on the phone right away, and we will help you triage the level of urgency of suicidal ideation. There are many steps that you need to take before you actually say, okay, go to the ED. And so we'll do that. We'll get on the phone with the patient. We'll get them to where they need to go. Oftentimes it's stay in the program. We get them better. So we're keeping patients out of the ED unnecessarily. And then ultimately, what I consider full integration into a health system or a clinic is where not only are you providing all these essential components of care that are difficult for medical providers to do themselves, but also we are aligning financial incentives. So the clinics, the health systems make money by partnering with us. I deeply care about training the next generation, this workforce, to be able to meet the demand. There's such high demand for this type of care and such a shortage of providers to be able to meet the need. And so, because there were no coach certification programs that existed at the time, we built them. We built a perinatal mental health coach certification. We built a menopause coach certification. All of our coaches are incredibly well trained and approach. The only requirement to be a coach at FamilyWell is to approach with empathy and curiosity. Many of our coaches, especially on the perinatal side, have lived experience and are doulas, IBCLCs, midwives who want this additional layer of mental health training. On the menopause side, our coaches also have lived experience going through perimenopause, menopause, and want to give back. So you don't have to have a mental health or a medical background. We will teach you how to apply CBT in your coaching sessions. We will teach you how to structure coaching sessions. We'll give you hands-on experience before you go out into the world and coach. And the perinatal mental health coaching program is open to the public. Perimenopause is not yet open to the public. And then in this next phase of growth at FamilyWell, we're going to be investing in CE opportunities for providers, building partnerships with graduate programs to build out our pipeline of providers who can take care of patients across the country, and then really creating a community for collaborative community for people to come and learn about women's mental health. So FamilyWell's coaching program really sets us apart. We have been certifying our own coaches. We want to be able to ensure that the quality of the coaching care is very high quality and standardized, which is another reason we did this. And then we've been working on training. We've trained over 100 coaches in the last year. And this coaching model not only sort of increases the workforce, but also lowers costs and accelerates scale. Because so many women, myself included, when I was going through this, I did not feel like I needed a therapist as a first step. I wanted somebody who could just tell me everything was going to be okay, be in my corner, and help me get through my day, give me some tangible skills to set boundaries with my mom who was not, in my case, was not able to really help in the way that some mothers are, because she had her own medical problems. And but how do I set those boundaries? How do I communicate with my partner? We do partner coaching as well. We bring the partner into the coaching session. So I believe every new parent should have a coach, could benefit from a coach. I wish I had had one. And I think that this is truly a unique part of what we do. Okay, a couple more slides, and then I'm going to open it up to questions. So, because coaching really wasn't a therapeutic modality, we wanted to make sure that it was working and that coaching itself by itself was effective. So in our first paper, we looked at cohorts of women with the same diagnosis, so moderate to severe depression or anxiety. We had two cohorts. One got ongoing therapy and one got ongoing coaching. And the average number of sessions to remission. And the other important distinction is our therapy sessions are an hour long and our coaching sessions are 30 minutes long. So the average number of sessions to remission for the patients in the therapy cohort was about eight, and in the coaching cohort was 9. And so this paper, these data showed us, validated that, look, the way that we're training and certifying our coaches and the way that they're delivering their care is actually really effective. It's working. And so this was really great. And then after this paper, after these data came out, we then decided to integrate coaching into every acuity level. Before, for high acuity, we were really just focusing on ongoing therapy. But then we said, look, coaching could be really effective even in the high acuity patient population. So we integrated coaching into all acuities, and every FamilyWell patient now gets a coach. All right. I was not looking at the chat at all. So if you have questions, let me see. If you haven't thrown them in the chat yet, please do. Or feel free to ask the question live.
Actually, we do have a question, Dr. Galton.
Oh, great.
Yeah, the first question is, can you talk about any differences in your approach with co-occurring SUD and the perinatal patient population regarding management, stigma, and primary care provider comfort?
Great question. It's particularly important because SUD is so it co-occurs with mental health conditions, right? So often in the perinatal period. So we have been fortunate to partner with community programs. And so what we do in our intake is if SUD is your number one concern, or let's say it's IPV, right? Like DV or IPV. Then we will find you the right program in the community that you're in, help you get stabilized from that perspective. And then if you still need us, you can always come back to us because oftentimes, sometimes SUD programs don't always specifically focus on the perinatal patient population. Um, and so we do not currently do SUD care in-house, but we will coordinate that care, get you to a program, and then have you back for the perinatal mental health piece after you're stabilized. But it's really, really important and it co-occurs and we screen everybody for SUD.
Okay, awesome. That's great to hear, though, that you are screening everyone for SUD and supporting them, right? Whether that's
Mhm.
in-house or getting them where they need to go.
Absolutely.
I don't want to call you out, Rachel, but did you have any more questions on that? You're welcome to come off mute if you want to expand, or there's some other piece that you wanted to know about.
That's super helpful. And I am a time zone behind in getting my little kids off to school. So any other questions, I'd be happy to maybe follow up with an email. But thank you so much, Dr. Galton. That's really helpful. I appreciate it.
Of course. Yes. And I understand the getting the little kids off to school piece.
Absolutely. Looks like we're having another question right now. Is there an effort beyond these webinars to incorporate this approach into, I think it's the medical school experience at any programs? It says media, but I'm thinking medical school experience at any programs.
Yeah, oh my gosh, so much to do, right? So I think no, we haven't approached that yet. I think it's critically important though, because Colette, what you raise is one of the problems, right, in our system is as a neonatologist, right? I spent 15 years training to become a neonatologist. And I had one slide in one of my medical school lectures talking about baby blues. And that was it. There was no other training. I did not know what the difference between baby blues and PMADs were coming out of my medical training. Um, I did not get any training in my neonatology fellowship on this at all. And that's probably one of the reasons why I missed my own symptoms for a really long time. I was struggling, looking back, I was struggling after my first baby was born, but didn't recognize it until after 6 months after my second was born. So it is so important. If you want to tackle this with me, please reach out because this is our our part of what we want to do through the FamilyWell Academy is really our get this training embedded into medical schools, into graduate schools, into as early as possible, right? Maybe someday elementary schools, who knows? But it is incredibly important and part of the problem.
All right. Thank you, Dr. Galton. We have another question. It says, I'm curious about the distinction between care managers and coaches. Would you describe that as a split behavioral health care manager role? Two people sharing the traditional responsibilities of a behavioral health care manager? And then the second part, what led you to separating those responsibilities?
Mhm.
Therapy is already provided by a different person.
Yeah, great question. So we started where the behavioral health care manager, we had many iterations to this role. We started where the behavioral health care manager did everything. They did the care coordination, they accepted referrals, they updated the registry, they did the targeted, mini therapy sessions, and quickly realized that that is not possible to do all of that in one person at scale. And so then we started breaking up that role into very concrete roles. So actually the behavioral health care manager role, the care manager role now is incredibly narrow. Um, Basically, their role is to manage, coordinate referrals, and make sure that patients are progressing through the program appropriately. Um, and the caseload is pretty tricky. In the traditional collaborative care model, your caseload you're supposed to have a caseload of at least like 100 to 120. Um, and that's just impossible to do if you're doing 10 different roles at one time. So then what we did was, okay, we know coaching. We've always started with coaching. We started actually before collaborative care started refining the coaching role and the coaching as an intervention. And so we said, okay, well, in the original collaborative care model, the care manager is supposed to do these targeted 15 short sessions with a patient that are like mini therapy sessions. Well, why can't a coach do that who has the appropriate background for a behavioral care manager, right, to be billable? So then all of our coaches are essentially care managers, but their role is specifically coaching. Um, and they have a slightly different background than our care managers. So basically, at scale, it's really, really hard to have a single person doing everything.
Mhm.
And so that's why we split it. And then over time, we've split this role and narrowed it even further. And so now we have like essentially a care manager team doing the work behind the scenes.
That's amazing. Wow.
Did that answer your question?
Okay. Yes.
Perfect. And Sarah, feel free to reach out if you have additional questions. Happy to share more.
Okay, here's another question that we've got. Um, have you considered AI coaching with vetted algorithms that your team can create?
Oh my gosh, love this question. We have definitely thought about it. There is obviously like a huge push for AI to integrate AI into behavioral health care. Um, what we are doing at FamilyWell is not replacing the coach because that human connection, I believe, is so incredibly important. Um, I do not want to take away that human connection. What we're doing is equipping our providers with AI tools to make their jobs easier and to make their coaching sessions more impactful. So that's how I think about how AI can support our providers. I don't think that at least at FamilyWell in the next foreseeable future we're going to be replacing our coaches with, an AI program.
Mhm. That's awesome. Great question, though. We hear a lot about digital apps and online services. So great question. Other questions, other thoughts? So I'll go ahead and ask a question. One of the things that we're thinking about is um, we have been working, and we've got our partners, I think, on this call. We've been working with UALR, which is a graduate MSW program here in Arkansas, and we are going to be in the fall working on placing MSW internships in OBGYN clinics, trying
Mhm.
to do some integrated programming. Any suggestions on how to engage with those clinics? We've had a little bit of a challenge doing that. And so curious, any tips that you have
Mm,
for us on
mhm.
how to how to engage them in these programs?
The providers themselves, yeah. Um, that's a great question. You know how I start is I typically get connected to an OB/GYN provider who is incredibly passionate about mental health, and make them your champion, right? Like make them your partner and champion, and make sure that that person understands what you're trying to do in the mission and the vision behind the programming. I think if you can find a provider in that clinic that is really excited about mental health, um, they will get everybody else on board. So that's typically how I'm able to engage with practices, is that there's usually one physician or somebody. It doesn't have to be a physician, it could be like a nurse practitioner or a PA or somebody in the clinic who's just like, we need this, I'm going to be the champion of this, I'm going to make this happen. And then from there, getting buy-in is much easier.
Fantastic.
I'm happy to also, if you want to, I could pretend to pitch to you at some point. Not right now, but I'm
Yeah,
happy to like give you my spiel if that's helpful.
absolutely. I will definitely be following up. Awesome. Okay. And it looks like someone gave a shout out with some willingness to connect. We appreciate that. Thank you so much, Amanda. Other questions that we have for Dr. Galton? Oh,
This is my family. I would not be doing this. I'm doing this for the next generation, this work, so that when my kids have their own kids, if they decide to do that, that their families have the support that they need, and hopefully preventing the next generation from the suffering that some of us have experienced. And so I just want to give a shout out to my family for supporting. Like, my kids watched the our marketing video on our website this morning, and I said, don't watch it in front of me, I don't like hearing my voice. And they watched it, and I asked them, I said, what do you think, what did you think? And they're like, you said too much. but but they hear about FamilyWell. They know what our mission is about. They see the hard work that my team is doing behind the scenes, because I'm constantly on meetings that they're overhearing, and I'm excited that they have been exposed to this, and hopefully it'll be a little easier for them.
oh my gosh, absolutely. What a beautiful family. Um, thank you. I think, and part of why we're so grateful that you're here and talking to Arkansas about this is, we have, as a state, we struggle with one of the highest maternal mortality rates. And so, listening to you talk about PMADs and, listening to you talk about the critical period really is not just the first few days after the birth, but the entire year, and learning about those risk factors of increased suicide up to the entire year, I think is so important. Um, and I think sometimes as busy moms, the focus is on the baby, and we
Mhm.
forget moms can be struggling, and we need to be screening, and universal screening such an important way to identify and address that. So, any last minute, knowing that Arkansas has one of the highest maternal mortality rates in the country, any advice to us
Mhm.
as a state on a potential next step or thoughts on what we can work towards?
Yeah. Yeah, you know what? I didn't go over this, but it's important to just review the ACOG clinical practice guidelines from 2023. I have a couple of slides that I can share with you as a supplement, Kim, that you can distribute on this. But basically, ACOG is now recommending screening at your first OB visit, screening at later in pregnancy. Usually, the OBs that we work with screen at 28 weeks, and then at every postpartum visit. And so and so screening is a first step. It's a really important step. The other thing that ACOG recommends is, if you're going to prescribe SSRIs, which 85% of OBs feel comfortable doing and are doing in practice, you have to rule out bipolar disorder. So we always do that in the first intake session with a therapist. Um, and then beyond that, being ready to have a solution, right? A lot of providers are hesitant to screen in pregnancy if they're not doing it yet, unless they have a solution. So it's great to focus on screening, but you have to be able to say, okay, well, I have a solution for you. What's next, right? Because if I screen more, I'm going to detect more, and still not going to have anywhere to send my patients. So that's why we exist. And we want to be that next step. We want to encourage and help. We do with our practices that didn't screen in pregnancy originally. Like, once they partner with us, they feel comfortable screening more because they know that their patients will get the support they need. So I would encourage you to think about, if you're thinking about additional screening, to have a solution that you can present to providers with, right? Like, if you screen, then do this, right? If your patients need help.
And potentially bake in the COCM model so that they
Yes.
have, you know, the psychiatric consultant support as well as the BHCM doing coaching calls and doing the
Yes.
flip.
Absolutely. Absolutely.
Awesome. Wonderful. Okay. Well, just wanted to get your input on that. We appreciate that and we appreciate all you are doing. And it sounds like you are just moving across the country. 5 states is huge. Wow, lot going on. Thank you for your time. I personally will be reaching out
Thank
with
you.
some
Thank you, Kim.
more questions. And I just want to thank everyone for being on today's call. Next month, we will be having Casey Copeland, a director of peer recovery specialist, and he'll be talking about the role of the peer recovery specialist and also thinking about how do we include a peer recovery specialist on the care team. So stay tuned, join us, and we will get these slides posted. Thank you all. Have a wonderful day.
Well, thanks everyone. Have a great day.